Hello, good afternoon, everyone. On behalf of the Systems for Action National Coordinating Center, my name is C.B. Mamrell, and I'd like to invite and welcome everyone to today's Research in Progress webinar on state dissemination and implementation strategies and local health department accreditation readiness and QI maturity. Before we begin, I'd like to acknowledge the Robert Wood Johnson Foundation for its funding and support for the Systems for Action National Program. And also, I'd like to remind everyone that if you have any questions about the presentation at any time, you can type in your questions at the lower left-hand corner of your screen in the chat box, and we will try to get to your questions at the end of the presentations. So without further ado, it is my pleasure to introduce to you our presenters for today, beginning with Dr. Adam Atherly, who is a professor in the Department of Health Systems, Management and Policy in the Colorado School of Public Health. Adam's main area of research is health economics, with an emphasis on the economics of aging and consumer decisions regarding health plan choice and health. Adam has been working in public health services and systems research for several years, with an emphasis on measurement and economic issues. Adam has also completed many cost-effectiveness studies and has experience in health outcomes research, including scale development and evaluations of efforts to improve quality of care and patient safety. Our other presenter is Lisa VanRaemdonck, who is Executive Director of the School of Public Affairs Institute for Governance at the University of Colorado, Denver. Previously, Lisa served as Executive Director of the Colorado Association of Local Public Health Officials, as well as Co-Director for the Colorado Public Health Practice-Based Research Network. Lisa's work is dedicated to supporting the intersection of the school and public service professionals through strategic partnerships, leadership development and training, peer networking, capacity building, and policy communication. So with that, I'd like to turn it over to you, Adam and Lisa, for your presentation.
Thanks, CB. This is Lisa. I'm going to start us off here and give a bit of an overview of our project. This is a vast project that has lots of components to it, and today we're presenting just a piece of those components. I know we've seen some of you in other presentations that we've given about this project, and if you're interested in some of our earlier work, there is a recording of the webinar we did for the Research in Progress webinar series about a year ago, so we'd welcome you to catch that one as well if we don't cover everything that you were hoping we would cover today. So, of course, we wanted to start by just acknowledging that this work was an enormous group project, a big team project across 3 different states, and a tremendous group of people, some who were students that worked with us and now are PhD professionals, and some who are still embedded in working in their own state. So it was one of the parts of these directive projects, if you're not familiar, was an attempt to work across multiple PBRNs, and so we learned a lot, our 3 states together, in trying to do cross-state work like this. This was, as I mentioned, a directive project funded by Robert Wood Johnson, and generally we have no other conflicts to disclose. Just a quick outline. I'm going to give you a brief overview of the project, and then I'll turn it over to Adam, who will share with you pieces of some of the findings that we have had in our project, and then we'll hear from our esteemed commentators about their thoughts. So just a little bit of background. This project itself is couched in the conversation in the work across the public health system, mostly governmental public health system, in quality improvement and accreditation readiness. And we know that these 2 things are very intertwined. And what we've seen over the years through the lead up to the development of national voluntary accreditation, as well as the work once FAB was created, is that there have been a variety of ways that states and state-level partners have supported local public health agencies in doing this work. So you may know some of the names of these programs: the NIPI program, NACCHO Accreditation Initiative, the MLC, and most recently Gaining Ground. And our interest was to look at what are some of the benefits, are there benefits to these state-level investments. These state-level investments are, as you can tell, often funded by our large national and foundation funders, and wanted to take a look at do they collectively cause an increase in the quality improvement, maturity, and accreditation readiness, or readiness to apply for accreditation within local public health agencies within states, and especially to take a look at are there differences among the states and how these state-level activities have been operationalized to help us learn how to implement these state-level processes to be more effective in states. So that was kind of the big picture question that we were looking at. Just quickly here, some of the research questions that we were looking at in this project. Again, a large project, so what we did is visually for ourselves as a team, and then in these cases when we're presenting to partners and interested folks, try to give ourselves a graphic representation of all of the many pieces and parts of this. So I'll just quickly walk us through this, and hopefully that will give you a little bit of a stage setting for what you'll hear today. So I'll start looking at the box that says state-level implementation structures. These are the places and the programs that are at the state level. They might be in a state health department, a state affiliate of NACHO, a state affiliate of APHA, perhaps a public health institute. These structures and programs lead to and support our boxes here of local health department quality improvement and accreditation readiness. Within quality improvement, we think there's a couple of ways that we measured quality improvement activity at the local health department level. One was QI maturity, and you'll hear more from Adam about that. Another is QI inventory. So we did an inventory collecting all of the types of QI projects, the discrete QI projects that were performed. In this project, we also thought that if health departments were preparing for accreditation and if they were doing quality improvement, we might be able to see change in health outcomes or health outputs. And that was the MPROVE measures. These are, if you've been in the PHSSR world for a while, a whole other set of projects that collaboratively across multiple states created some measures. And then you'll see a couple of other places where we added some other measurement that we wanted to do. So a little bit in cost. Could we get a sense of how much it costs to do a QI project? Looking at some of the network connections, were these activities developing stronger networks between our state partners and our local public health agencies in each of our states? And then at the front end here, we wanted to see if we could measure the actual dollar investment. So those of you that work in state health departments, you can imagine the challenge of trying to get a state health department to tell us the value or the actual dollars that went to local public health to support QI and accreditation. It was a measurement challenge in and of itself, and we'll talk today a little bit about how we did that. So before I turn it over to Adam, one more sort of contextual thing when we think about our 3 states. Some of you may know one or more of our states, but let me give you a little bit of sort of the environmental context of our 3 states. We're all decentralized public health systems, so have an independent state health department and then somewhere between 20 public health agencies in Nebraska all the way up to over 100 in Kansas. So those are individual independent agencies. And the conversations in our states and our state governmental public health systems about accreditation and quality improvement have ebbed and flowed over time in our 3 states. I would say Kansas, if you're familiar with the multi-state learning collaborative work, was in that work. And so early in the conversations before FAB was really created, and talking in Kansas very early on about regional sharing of services and those sorts of things. They have, as you probably know, a lot of politics in Kansas around government and around public health that has bled into the conversations, not necessarily in a positive way, around accreditation. So while they've had some early conversations, that hasn't quite necessarily been consistent. In Colorado, we hadn't really been talking very much about accreditation or QI. We were not involved in the MLC early on. However, we were building the legal structures and requirements that would prepare our public health agencies to be ready for accreditation. So in Colorado, we have a requirement for all local public health agencies to create a community health assessment and a community health improvement plan, 2 of the prerequisites for accreditation. So while we didn't have these robust conversations about QI and accreditation, we did have some of these policies in place. And then Nebraska has had a more consistent and long-term kind of running conversation and funding directly to local public health agencies and support mostly from their state health department. So a clear connection between their state health department providing technical assistance and funding and training to their locals, perhaps at a more consistent and sort of long-term sustained level than our other states. So you'll start to see some of those contextual environmental things bear themselves out in the data and information that you now hear from Adam.
Thanks, Lisa. So this is Adam. So what we're going to try to do is we're going to try to walk you through the different pieces of this project. And as Lisa said, this is a project which had a lot of different pieces. The first piece we want to talk about is the quality improvement and accreditation readiness. And first I'm going to talk about how we did the measurement piece of that. So starting with the quality improvement, Brenda Jolly and people at the Minnesota Department of Health developed just a terrific tool to measure quality improvement in local public health agencies. So what we did to measure quality improvement was we took that tool and then we did a slightly smaller version of it to reduce the number of questions, to reduce the respondent burden for the agencies that we surveyed. That QI maturity scale looked at three different aspects of QI maturity. It looks at the organizational culture, so trying to look at the values and the norms of the agency, capacity and competence, so again, the skills and whether or not they are in a good place to do quality improvement, and then alignment and spread, so the extent to which the ideas about quality improvement are realized throughout the agency. We took that tool, and as I say, we took a subset of questions, and then we just took these 10 questions for people to answer. We redid the scoring system a little bit to get it out there. The great thing about the QI was that there was, again, that people at Minnesota had developed this off-the-shelf tool. For accreditation readiness, we didn't find that quite as much. So we needed a valid and reliable measure for accreditation readiness. So what we did was we drew questions on accreditation readiness from a whole bunch of different places. And then we developed a survey with 15 different questions. And then we went ahead and gave that survey out to the local public health agencies. And then we used confirmatory factor analysis to try to see how the different questions organize themselves into different domains. We tested the survey for reliability and validity, and it actually performed pretty well. We had a reliability score of 0.81, and we had a factor correlation of 0.49. So psychometrically, it did pretty well. And then we ended up with a final survey which had 8 questions covering 3 different domains. And that was preparation for accreditation readiness, planning and approach, and support for accreditation. And so those were the 3 different pieces that sort of come together to be accreditation readiness. So once we had the surveys then, again, we put those out to the local public health agencies. So our surveys were filled out by 156 public health directors across the 3 states at local public health departments. For both Kansas and Nebraska, we actually got a 100% response rate. So all local public health agencies filled out the survey and returned the data to us. For Colorado, we had a 67% response rate, so 36 of 54 agencies responded. Then we supplemented that. Then that gave us information on accreditation readiness and QI across the local public health agencies across the 3 states. The second thing we need to know is we needed to know how much people were spending on these activities and where the money was coming from. So we conducted key informant interviews with state-level partners, and Lisa and the research team and again, all the partners across all the states did a whole lot of information to get information on state champions, leaderships, funding, and all those kinds of things. Okay, so next we're going to talk about some of the results then. So this is the slide just showing the descriptive statistics for quality improvement, showing you the differences across the 3 states on our scales. And again, these are 0 to 5 scales. So what you see as you look at this is for QI capacity and alignment in particular, you see much higher scores in Nebraska than in Colorado, and to a lesser extent to Kansas. And a lot of the funding and the efforts in Nebraska are really done centrally through the state, as opposed to Colorado where it's much more diffuse. This is for accreditation readiness, and again, for preparation for accreditation readiness, again, you see much higher scores in Nebraska. Those are statistically significant difference. The support for accreditation, also you see higher scores in Nebraska, and again, that's also statistically significant. And then what this is showing you is what we also did is we looked for heterogeneity. We did this with an ANOVA analysis where what we did is we looked for whether or not there were differences in accreditation readiness and quality improvement within the states across the size of the jurisdiction. And what we found is that for 4 of the 5 measures in Colorado, there were differences across population sizes, and larger jurisdictions had higher levels of quality improvement and accreditation readiness. And we also found the same thing in Kansas for all 5 of them. And interestingly, for Nebraska, there was no heterogeneity. So regardless of the size of the jurisdiction, they had statistically similar scores on QI and accreditation readiness. And again, here's the state level investments in it. And again, what jumps out to me as you look at these numbers is that, again, if you look at Colorado, for example, there's almost a 3-fold difference in funding between the 25th percentile and the 75th percentile. Again, if you compare that to Nebraska, it's a much smaller difference both in absolute dollars and in percentage terms. And Nebraska also just has flat out higher funding levels. And again, you also see that to a lesser extent in Kansas. So just much more heterogeneity in spending in Colorado than Nebraska, with Kansas kind of being in between the 2 of them. So when you summarize those descriptive results, what we see then is we see differences across the states in preparation, planning, and support for accreditation, but not so much for planning and approach. And for QI, we see differences in capacity, alignment, and spread and maturity, but not for culture. We also see differences in QI and accreditation readiness across population sizes in Colorado and Kansas, but not Nebraska, and then we see big differences in state investments. Okay, to try to tease this out a little more, we then put this into a regression. So what we really want to know is to what extent system-level investments in local public health agencies improve quality improvement, maturity, and accreditation readiness. So to do this, we ran a regression. Our dependent variable are the 6 measures or the 7 measures we've been talking about, the 3 scales for accreditation readiness and the 4 scales for quality improvement. The control variables we put in were investment amount, so how much was actually spent by the state on the state. We had controls for the state, controls for the jurisdiction and population. We had interactions between the Kansas and Nebraska state dummies and populations. That's to capture that heterogeneity in the idea that there's heterogeneity in the population size. And then we controlled for a whole bunch of things like this number of FTEs in the state, spending per capita, the size of it, the training of the directors, and the nature of the Board of Health. Okay, so now walking through the different regressions that I just mentioned, in terms of accreditation readiness preparation, the amount of investment mattered. So essentially, the more the state spent, the higher the accreditation readiness preparation was at the local public health agency. Controlling for investment amounts, Nebraska also just had flat-out higher levels of AR preparation. And then we also found having a director of the local public health agency trained in public health improved their accreditation readiness. And again, to interpret that, on these scales, if you want to increase your score on AR preparation by 1 point, the state has to invest about $32,000. In terms of planning and approach, the only thing that was really significant in our models was the investment amount. And in terms of planning and approach, it costs about $47,000 to raise the average local public health agency by 1 point. In terms of support for accreditation readiness, here's where we see quite a lot that's significant. Again, we're seeing this consistent theme, investment amount matters a lot. Here we see state differences. We again see that the training of the public health, the director of the agency matters, with higher scores for directors who are trained in public health. Turning to QI, For QI maturity, what mattered was the population of the agents of the jurisdiction. Higher populations have higher QI maturities. The size of the agency, so more FTEs controlling for population, and the physical size, the land mass. And I'll say that we did a lot. We looked at how to measure land mass in a lot of different ways. We tried measures of population density and some different things like that. And what we found is that both population and land mass have an independent effect. In terms of QI culture, the only thing that mattered was land mass. For capacity, again, we see a little bit of a state level effect. We again see the population land mass with bigger agencies, both in terms of population and size, having higher scores. And then we see some heterogeneity in Kansas for the first time. And then for culture, we just see state level effects. So if you put those together, in terms of improving scores or having higher scores on accreditation readiness, what mattered in the models was state level investment, the training of the director of the agency, and Nebraska. And Nebraska tended to do better. For quality improvement, the number of FTEs in the agency and the size, either through population or land mass, was what mattered. Okay, now turning to the next piece of this, which is looking at that link between quality improvement and accreditation readiness and improved measures, so kind of a health process measure. We spent a lot of time thinking about what measure we could have that would be consistently measured and consistently available across all the different states. And after a lot of discussion, we landed on the idea of immunization rates. This is obviously a core public health service, and this is something that is required in all 3 states and measured in all 3 states. And then the other nice thing was that on our QI inventory, we actually had an inventory for every local public health agency that responded to our survey on what quality improvement projects they were doing. And in every state had at least one local public health agency that was doing a quality improvement project directly related to immunizations. So we have 3 measures of immunizations. We have the proportion of kids vaccinated entering kindergarten is our first measure. The second measure is the number administered by the local public health agency to kids 0 to 5. And then the third is that same measure, the number of immunizations administered by the local public health agency to kids 6 to 18. This is, again, just descriptive statistics. In terms of measure 1, which is the immunization rates for kids entering kindergarten, really it's fairly flat. There's a little bit of a decrease for those who had a QI project in the area, but really not much of an effect. This has changed year over year. The second is looking at the effect for kids 0 to 5 and the number administered by the local public health agencies. And what you see is a big drop in agencies that didn't have a QI project and a smaller drop for agencies that did have a QI project. And then the third measure is, again, kids 6 to 18, and you see actually an increase in the number of rates for agencies that had a QI project in this area, and a decrease for agencies that did not have a QI project. And then if we put that into a regression, we can look at we're going to look at those same measures as our dependent variables, and we're going to control for whether or not the agency had a QI project related to immunizations. We're going to control for our 4 measures of QI, our 3 measures of accreditation readiness, some state dummies, again, these interactions between population and state to control for heterogeneity, and then the same control variables we talked about before. And what we find is you see higher overall, for measure 1, the overall immunization rates. Kansas and Nebraska do better than Colorado, but not better than each other. For measure 2, nothing mattered. There was nothing in the model that was statistically significant. And then for measure 3, the only thing that was significant was whether or not the local public health agency had a QI project related to immunization. And if they did, they had a positive effect. Okay. So limitations, there's a lot of limitations to this project. We talk about endogeneity, and that is, we are very well aware that there may be other things that are driving both things like state level investments and outcomes. In particular, looking at the effect of things like QI inventory or QI projects related to immunization on immunization rates. It's probably not random what local public health agencies decided to do these projects, and that's just a limitation of this kind of observational data. We also worried a bit about response bias in Colorado. We looked at that data, and as far as we can tell, there's no evidence from the data we have that there's a significant response bias. And as Lisa said, there's a whole lot of other pieces to this. We looked at we did a social network analysis as part of this, which we haven't talked about. We have data on the inventory, so we looked at the exact kind of QI projects people have done. We've done a cost analysis of different QI projects. We've done an analysis of rural versus urban. So there's a lot of other pieces here as well, and we just wanted to acknowledge that. Okay, I'll list.
So one of the other sort of pieces and also limitations that I wanted to add was that I meant to say in the beginning was this Gaining Ground initiative. For those of you that are familiar, there were a handful of states over the past couple of years that had some extra funding to do some extra collaborative work at the state level to support local public health agencies in QI and accreditation readiness, and both Nebraska and Colorado were in the Gaining Ground cohort. So that was actively occurring as we were doing this research. What it means is that, we know anecdotally in Colorado, things have changed since we collected this data. We have, 4 public health agencies that are accredited now. Our state health department is accredited. So part of that is just the challenge of, in some cases, PHSSR broadly, in some cases just trying to have observation points that we can do clear research on during a very dynamic time. So that is something that we just know is a limitation and especially in our translation. So overall, I think there is a story here about PHSSR and our attempts to get really solid at measuring and doing rigorous analysis. I think we think we've shown that we can measure QI, we can measure accreditation readiness using valid and reliable tools. In our findings, we think that it looks like some more centralized funding mechanisms can potentially reduce variation, especially in QI when those funds are directed in that space, and that the interesting piece about accreditation readiness being associated with state investments, but also the training of the director, and that public health training, in some level, associated with the ability or the support and interest in applying for accreditation. We knew that we were going to be sort of testing the limits of PHSSR in trying to tie this to improved measures or to the immunization rates in specific. It was a great exercise for us to try. It was great to try to come up with the measure that we would use together and really engage in that activity. But there is sort of limited evidence there, and I think lots of room for others to take this forward. So at this point, that is sort of the end of our presentation. Happy, CB, to turn it back over to you for the rest.
Thank you, Lisa and Adam. And before I introduce our commentators for today, I'd just like to remind everyone that you can type in your questions at the lower left hand of your chat box, and we'll get to that after our commentators and our presenters give their response. So without any further ado, I'd like to introduce to you our commentators for today's webinar, starting with Dr. Les Beitsch, who is on the faculty at the Florida State University College of Medicine as Professor of Health Policy and Director of the Center for Medicine and Public Health. Les is currently Chair of the Department of Behavioral Sciences and Social Medicine. He also serves as a member of the Board of Directors for the Public Health Accreditation Board. And previously, Les was the Commissioner of the Oklahoma State Department of Health and worked for the Florida Department of Health at the state and local level for a dozen years. Our next commentator following Les would be Jessica Wehle, who serves as Senior Manager for Performance Improvement Initiatives at the National Network of Public Health Institutes. Jessica works closely with the Centers for Disease Control and Prevention and the Robert Wood Johnson Foundation, managing a variety of quality improvement and performance management projects, including a peer learning network and a community of practice focused on performance improvement and accreditation. So with that, I'd like to first turn it over to you, Les.
Thank you, CB. And I'm delighted to be with all of you today and to hear about the research project from Lisa and Adam. And I describe myself as really a pracademic or a recovering health official and public health practitioner. So I'm going to really think a bit through that lens. And if I had to come up with just sort of a global conclusion, what did I get from this? I would suggest that all of us move to Nebraska as soon as possible. So that would be my takeaway. And with global warming, it really may not be that bad this time of year there. Thinking more practically about that, I think this research project was very thoughtful and extremely well executed. And I think the findings that we've gotten are very consistent with other work that's been done in this area. And I'm going to point to actually some work that I participate in as well. An article, National Voluntary Public Health Accreditation, Are More Local Health Departments Intending to Join the Queue, was published last year in the Journal of Public Health Management and Practice. And we found some things that were very comparable to what was found here, although these findings are far more granular. But we found that probably the single biggest driver for local health department involvement in accreditation was state health department participation. And again, you see how that relates to, in a manner of speaking, with what Lisa described as kind of in their postmortem conclusions. I really like the conceptual model that Lisa and Adam laid out. I think it's a very thoughtful representation that's very consistent with personal observations I've had over the years working in accreditation, being part of the Multi-State Learning Collaborative for many years, and FAB research agenda. I think it's very consistent with the things that we have found. Likewise, I'm familiar with the Brenda Jolly, University of Southern Maine, not so much the Minnesota revision of their QI maturity model. And I think what was presented, which was utilizing a subset of those measures, was really, again, conceptually very interesting. I know most of you didn't have a chance to look through, maybe we will in a little while, some of the questions that were in that 10-part model. One of which was customer satisfaction, which in public health is a somewhat underutilized measure. Lisa touched on this. When we think about Colorado and Kansas and Nebraska, they all have very different structures, very different public health histories, very different attitude towards roles of government, very different attitudes about the capacity and the role of the state health department. And I think some of the nuance and the findings here really teased out some of those differences. So, when I was thinking about accreditation readiness and thinking about it through both a research hat and a practice hat and kind of an experiential hat really, that to me it makes a whole lot of sense that the two findings were that money matters and public health background and training, of the director. And I would say that makes, inherent sense, that accreditation for many health departments is an activity that someone needs to step up and actually do. So health departments that have resources can have an additional FTE that is dedicated or can dedicate more time to that work. On the other hand, we didn't see that with quality improvement, and I think that's also intuitively right, because quality improvement, to really get to a level of quality improvement maturity and a culture, it's got to be spread throughout the entire organization. So merely investing in one person may not be sufficient to actually disseminate quality improvement throughout the organization itself. So if I was to summarize here, and I will, I think this was excellent research, very thoughtful models, well executed, and it provides insight into state-level systems and how they influence accreditation readiness and quality improvement. And I'd like to see others pick up on this work and tease it out across states across the United States. So thank you.
Thank you, Les. Jessica?
Hi. So I just wanted to say thank you all very much for allowing me to come on and provide some commentary on this really wonderful work that you all are doing. I want to echo what Les was saying about the fact that this is just a very thoughtful approach and ultimately will help add to kind of the evidence within public health around quality improvement and accreditation readiness. And so for that, I thank you all for your efforts, and had the opportunity to speak with Lisa earlier this week, and through my projects that I work on through CDC and Marber with Johnson, I've gotten to see quite a few different areas that this type of work touches on, particularly working with the Gaining Ground group, where 7 states created coalitions and had begun to try to diffuse the idea of accreditation preparedness along with QI throughout their states. And Colorado and Nebraska were 2 of those, along with some other states throughout the nation. And one of the big things that we saw and that Lisa touched on was through those national efforts that had been funded, into the state level, but also providing some of the local support as well, was that peers really enjoy sharing. And so once the information has been shared with one group through an investment, say to Colorado, then you have some diffusion, because Colorado may come to a national conference like the Open Forum for Quality Improvement in Public Health, which is funded by Robert Wood Johnson, or the Public Health Improvement Training FIT funded through CDC. And both of those are where Colorado, as peers or practitioners, would be able to share with others and kind of diffuse and move the thought throughout. And so one of the key things that came to mind regarding the value of this to practice is the investment at the state level means quite a bit for the state, as Les mentioned, but what it also means is a diffusion of that knowledge, and so they become their own experts, their own subject matter experts, by just investing within these other areas and subsequently in peer networks. And so at the beginning, Lisa mentioned some of the other national efforts going on, but a few others that there is additional funding for was like the Accreditation Support Initiative, ASI. So that's offered through APHA, through ASTO, NACHO, and the National Indian Health Board as well, to help move certain areas and certain groups into accreditation readiness. So again, those all have their own learning networks and communities that they're really able to help then take that message and share with others who may not be as fortunate to get that funding source, but can still share. So we're seeing a lot of growth in the peer network and the peer sharing, which means quite a bit as far as the information getting out further. And as far as just a thought for the future research that you all are looking at, I would be interested in seeing what impact those possible peer networks are having on accreditation readiness, or QI. And one of the things anecdotally that comes up, and we hear all the time from the national conferences that we host specifically around performance improvement, QI, and accreditation, is usually there's a lone voice of a staffer doing QI, as Les mentioned, one person kind of tasked with that work, building a culture, et cetera. And when they get to come to national conferences, they get to geek out on the topic with other people who really love this and are invested. And it refreshes them, and it really helps them kind of find their purpose again, like recharging a battery. And so they get to take that and bring it back again. Some of the efforts that we've been doing around that are the Communities of Practice for Public Health Improvement, COFFEE, and then we also have the Public Health Performance Improvement Network, PHPIN. And all of those are stakeholder-driven, and so it's the practitioners in the field really talking about what work is doing and how they're sharing. And one of the limitations that kind of came to mind when Lisa and I were talking was because the self-reporting nature of some of these assessments, public health staff tend to be extremely modest about their accomplishments. And so the reporting may be quite a bit less than we're used to. There's always going to be a few who are kind of over as well, but I think the bar is lower. And so, or they don't consider it formal QI efforts that they're doing, but they are doing improvement. And so there's a few variations that came to mind when I was listening to Lisa and Adam as they were going over their project. And the other big piece I just wanted to kind of summarize on, generally the practitioners that I hear from and work with, they don't understand how innovative and wonderful some of the work they're doing in performance improvement is. And really it's because out of necessity, they don't have the tools, the resource, or the access to trainings, and so they're coming up with some really great innovations. And they are more than willing to share with their other peers, so not everyone has to reinvent a wheel. And that's where I kind of see that practice piece coming out of what Lisa and Adam were presenting. So I'll go ahead and kind of summarize on that, and it's always interesting to see how this kind of shakes out in practice.
Thank you, Jessica. Thank you, Les. And before we return it to our speakers, our presenters, to be able to respond to the commentators, I'd like to again invite everyone who has questions to please type in their questions in the lower left-hand corner of your screen of your chat box. So we want to first give an opportunity to Adam and Lisa to respond to the commentary. So Adam, Lisa, we'll just turn it back to you first quickly.
Thanks. Well, thanks, Les and Jessica. We knew that you all were going to provide thought-provoking things. Adam and I were on mute and talking about other research questions already over here. So thanks for inspiring that. I think, Jessica, I just want to lift up something that you mentioned. We do have this very small portion of this large project that looked at the network. I know what we have witnessed is what you're describing as well, is a lot of network change. And when we think about this diffusion of innovation, I do think there's future larger research here about the quality improvement network, looking at who those people are within their health departments, who those people are within their states, who are attending these conferences and trainings together, and then where does that go, right? I think we all have attended a conference and learned a lot of stuff and went back to our normal job and didn't really change anything, right? So there's something there about that diffusion of innovation and this network that we've been building over time that is really interesting. So hopefully, for those of you on the phone and also who are in the business of coming up with research questions yourselves, this work and then hearing from Les and Jessica has inspired you to think of a few other ways that we could look at how we're doing in infusing this state and local connections on accreditation readiness and quality improvement.
All right, so we'll open it to the audience now for questions. I think we have one question here from Kasuma, who asks, how many total QI projects related to immunizations were in the inventory and distribution among the 3 states? What was sort of the general time frame that the QI projects were conducted?
Thanks. So we do have a quick answer to that. So there were 42 total QI projects that were reported across all 3 states. 12 of those projects were immunization projects, and that was by far, when we did a categorization of the types of projects and the topics, by far the largest. I don't already have the detail about how many of those immunization projects were in each state, but as Adam reported, at least 1 in each state. And then the time frame, we had asked for those projects that you had either completed or started in the last 3 years for the time point. And then our pre-post on the immunization data was prior to that 3 years and then after that 3 years. So the immunization data we pulled from each state was hopefully, and there might have been a little wiggle room there in terms of when the quality improvement project was actually started, but the intention was we looked at immunization data before you did your project and immunization data after you did your project.
So Antonia has a question. How was the QI inventory obtained?
Yeah, so the QI inventory was a survey. We're very much of the mind to start with what this tremendous community of researchers and practitioners have started. So we actually started with the inventory tool that is used by NMPHI in collecting QI project examples for the PHPN network. I think I have the right network, Jessica. I might not. And we took that tool and we simplified it, and then went back out to all the public health agencies. In our original survey about QI and accreditation readiness, we asked them if they had ever done a discrete QI project, and we asked them how many. So that gave us a sense of the quantity, and then we had this follow-up inventory survey where we said, you told us you did 3 QI projects. Will you please give us more information about each of those projects? And then part of the, my personal, as a sort of, thanks Les for using the word pracademic, is really an interest in making sure we're getting information back to our partners in practice. And so each of the states got a spreadsheet of all of the QI projects that had been reported by the public health agencies in their state, with the idea that they could use that in their work either internally within the state health department or state partner, or they could make that available to the local public health agencies so that those folks could go, oh, I didn't know you had done a QI project on X. We're trying to do that. Can you help me and enforce some of that peer networking? Now, I don't know how they were used, but we did do the work to try to get the data out the door so that it could be used in practice.
Thank you. So Sergey has a question I think Adam raised about the indigeneity problem. So Sergey asked, do you have any plans to account or control for the indigeneity issue?
We've got a pretty small sample size. Our sample is 156, and I think that's an issue that we're worried about. I don't think we can statistically control for it because I just don't. I don't want to push the data too hard. We're actually fairly careful in building the models not to try to overfit it as well. So I think, again, if you take the statistical controls off the ground, then we're sort of in the world of trying to do qualitative research to try to understand the factors. I mean, the good thing is we have a pretty good idea of the kinds of things that are likely to be omitted from the model and associated both with the variables we're interested in and with the outcomes. And so that's really the way we're trying to deal with this.
So if anyone has still more questions, you're always more welcome to either contact Adam and Lisa directly. But I guess I'd like to end our webinar by asking the question sort of what are the next steps? You did talk at the end of your presentation about these other pieces. And so for those who are interested in following, the research that you're doing in this area, are there avenues or, outlets that you're planning to disseminate the results and get feedback? Or, is there something you'd like to tease in? You were talking about some of the research questions you'd like to explore later on. So sort of, summarize sort of the next steps that you have for this research, Adam and Lisa.
Yeah, thanks. So as you know, the project is finished. We are still in the writing stage, so we've done a lot of presentations on this project, but the project team is really working on what we can get out there in peer-reviewed literature. So that's our effort now, and we've broken up multiple team members to work on different articles. So, I think what we reflect on in terms of what we just won't be able to say a lot about out of this project, especially the cost analysis. We have a couple of small case study looks at cost analysis, but that piece really could have been its own standalone project, and could have been, had the budget of the whole project that we had. So we feel like we played a little bit in that space and learned a little, but that could, in terms of future research, just really looking at what it costs to do QI projects could really be a discrete research project. We also, as I mentioned after Jessica's reflection too, this concept of network and how these networks are being built, these learning networks are being built, I think there's a lot of meat there as well that we as on our team are interested in, but that we know many of you are also interested in kind of network research. And we think in this QI and accreditation readiness field and in this governmental public health, state and local, and even federal governmental public health world, there's some real meat there. And when we look at the work we did in the network, analysis, we also think that could have been a whole other project with the same budget of our entire project. So I don't know how much we'll be able to say in terms of findings in those areas, but I would say if anybody's interested in developing their own research in those two areas, we would love to be thinking partners and sort of share the little bits that we've learned on an individual basis.
I think that ties in nicely to Antonia's question, who was asking, could you share the final tool used for the QI project inventory? So I guess they can get in touch with you directly, Lisa and Adam, for those kind of questions or collaborative opportunities.
Absolutely, yeah. Actually, the final tool that we used is the same tool that Minnesota uses, and they use it on the practice side. Their state health department uses that tool periodically, and they post some of the results with their scoring system on their website, the state health department website. And so we would be happy to share what we used and talk a little bit about how we changed the scoring for ourselves as well.
All right, excellent. So Lisa, Adam, is there any more final words you'd like to add?
You know, I think, this is Lisa again, obviously, I would just wrap up and say I know we've got a couple of our colleagues from Nebraska and Kansas on the line with us. I know y'all are muted, but clearly there was no way we would have been able to do this work without really active participation from all three of the states and ongoing active participation as we're trying to write up our findings and such. So go team is, I think, what I want to just end with. It's been great.
Absolutely right.
Excellent, excellent. Well, thank you so much, Adam and Lisa, for your presentation. We really appreciate the time and the research you've shared with us this afternoon. And thank you also for our commentators, Les and Jessica, for your time as well. And so we'd like to thank our presenters and commentators. And thank you also all for joining us. We'd also like to let you know that today's presentation, if you're interested, is available for download at our Systems for Action website, which we invite you to take a look at, including an archive of our past research and progress webinars too as well. And we'd also like to invite you to take a look at our upcoming webinars, and we hope to also see you there and invite you to those as well. So please take a look at that. And so with that, thank you everyone for joining us, and have a great day. Thank you again. Bye-bye.